Good morning and welcome to Medical Grand Rounds. Today's talk, COVID-19 and HIV intersecting epidemics, is sponsored by the New England AIDS Education and Training Center. Our Gilman Clinic here at Maine Medical Center, which is nearing nearly 30 years of care for persons with HIV and viral hepatitis, is a regional partner in the provision of educational programs related to HIV prevention and treatment. The past year has been largely consumed with challenges posed by COVID-19. HIV transmission continues here in Maine as elsewhere, and the challenge of providing care to all of the population that can benefit continues. We estimate that about 2,000 people in the state of Maine are infected with HIV, and about 85% of them are in care. And of those, the vast majority, or 80 to 85%, have viral suppression. Fortunately, although it took 15 years, we have excellent antiretroviral treatments that may consist of a single pill once daily to control the virus. But of course, no vaccine yet for HIV. On the other side, with COVID-19, as we all know, we've had remarkable experience and success with the production of vaccines, but still much needs to be done. We're very fortunate today that we have our speaker, Kathryn Stephenson, here, who can address both of these overlapping, intersecting epidemics. She's Director of Clinical Trials Unit at the Center for Virology and Vaccine Research at the Beth Israel Deaconess Medical Center, and an attending physician in the Infectious Disease Division there. Her research has contributed to development of a vaccine to prevent Zika virus, novel approaches to HIV treatment, and assessment of the efficacy of COVID vaccines and treatments. She's a graduate of Williams College and NYU Medical School. She trained in internal medicine and infectious diseases at Columbia and Harvard. She is currently on the faculty at Harvard Medical School. Among her many awards, it is noteworthy that she was selected in 2019 as the Boston Red Sox Medical All-Star, even though she's from New York. It's a pleasure to welcome Dr. Stephenson.
Thank you, Dr. Smith. Thank you all for inviting me today. Like everyone else, the last year has been all about COVID, but my day job is HIV research. So I've been working on HIV vaccines mostly for probably the last 10 years, and some novel HIV treatments. So it's been very interesting to see how things have played out this year with COVID. So first I want to say I am a clinical investigator, so I run a bunch of studies, and most of them are funded by the NIH. Some are funded by Regeneron, Gilead, and Johnson & Johnson. But I personally do not have any financial interest in any company or in any of their products. So if I mention them today, I don't make any money from that. So I'm hoping today to go over a lot of different aspects of how COVID-19 and HIV have overlapped this year. Mostly I want to focus on clinical aspects of this. So the clinical presentation and risk factors for severe disease, a little bit highlights about, how would you approach treatment and prevention in this population. And then in the end, I just want to talk about more big picture observations about how these two pandemics can really inform each other. So just to start with clinical features of COVID-19 and people living with HIV. So, right now we're in the midst of a feeling of, like a fever is breaking, and SARS-CoV-2 cases have come down so significantly, but they're not gone. And there's definitely hotspots of SARS-CoV-2 infection that occur. And this is more of a preface to say, here in Boston, for example, most of the test positivity rate is it's on average about 1%, and in a lot of communities outside of Boston, it's less than 1% or actually like 0 cases. But in some much more vulnerable communities where a lot of our patients with HIV live, the test positivity rate is between 2 and 3%. So depending on where you look, these infections are still occurring. So what do we know about how they present? A lot of this, a year ago, we had no idea how it presented in people with HIV. And the little we learned at first, was really gathered by descriptive studies of people who presented to various different hospitals. And the early data show that the characteristics of people who were living with HIV who presented with COVID-19 were that most of them had a comorbidity that was associated with severe disease. A lot of people with HIV at baseline have comorbidities. So about 85% of them had comorbidities that were admitted with severe disease. Just like everywhere else across the country, Black and Latinx patients with HIV were disproportionately affected. What's interesting, though, this was a study that was done at Mass General. It's not just relative to the general population that this was true, but actually also relative to people living with HIV, this was true. So at MGH, they looked at their own clinic of HIV patients, their panel, and saw that there was still among that group a higher proportion of Black and Latinx patients that were admitted with COVID-19. And some of the features they found among that population is that it was very common for them to have had an exposure to congregate settings, more so than their COVID-19 patients who didn't have HIV. And these congregate settings could be in jails or prisons or homeless shelters. But having said that, it wasn't that this whole population of people had very chaotic social lives such that they were completely uncontrolled HIV. In fact, about 90% of patients who were living with HIV who were admitted with COVID-19 were well controlled, 90% on ART with CD4 count over 200. ART, when I say that here, is antiretroviral therapy. At first, there was a question, maybe people living with HIV present differently. Maybe they come in more with GI symptoms and a rash, but it wasn't true. It turns out they present the same way as everybody else. 90% with cough, 65% with fever, 60% with dyspnea. So the presentation with COVID-19 looks very similar. So then you say, okay, I've got a bunch of patients with HIV that I'm following. What are some of the risk factors among that population that could predict who's going to do well and who doesn't do well? So the traditionalists of the last year, risk factors for severe COVID-19 really apply. So obesity and older age and diabetes, all of those factors really predict severe disease. In specific studies that have looked at people with HIV, it's been older age and chronic lung disease and hypertension, but really it's the usual players. What's specific for HIV and has now been shown in a couple of studies is really the host immune status seems to be very important. So in one study, for example, a CD4 count less than 200, which is a sign of real immune deficiency, was associated with severe outcomes, as was hospitalization in a different study, which was associated with the more advanced HIV disease, so stage 2 or 3 relative to stage 1. There's a question, okay, maybe these viruses really interact, like maybe having a high viral load or uncontrolled viral replication of HIV, synergizes with SARS-CoV-2 and that predicts severity, and that wasn't shown to be the case. So if you had an intact immune system, but you just weren't on treatment and you had a detectable viral load, that didn't predict severity. It was really your host immune response that predicted that. There was another study in Spain that looked at 77,000 people living with HIV on treatment that looked in more detail about what were risk factors for severe disease. And they saw some of those same features, such as being a man or being older 70, for example. Then they dug in deeper and tried to ask the question, is there a particular antiretroviral regimen that was really important? And actually not asking to say if there's a treatment that predicts severity, but rather, is there a treatment that is protective, that might actually have antiviral activity against SARS-CoV-2? So they looked at a bunch of different regimens, and I know you guys are not all ID doctors or HIV doctors, so you don't know necessarily all these different meds. But just take it from me, there's all these different regimens. And down at the bottom is just, some of their raw data, basically. Looking at TDF-FTC, which you may know as Truvada, showing that those patients that were on that regimen had pretty noticeable lower rates of COVID-19 diagnosis, hospitalization, ICU admission, and death compared to these other regimens. So they kind of jumped in their conclusions to say, hey, maybe this tenofovir, especially tenofovir TDF, maybe that actually has antiviral activity against SARS-CoV-2, and this could potentially be like a whole new direction for treatment. But they actually did not control for a number of different factors, which among HIV doctors is well known that if you have a patient, for example, who's has chronic kidney disease, you are going to change them from this TDF regimen to this TAF regimen. So you're already selecting out a population. So generally speaking, people on this regimen were healthier, and they didn't really control for that. And this study got a lot of criticism for not controlling for that, but also speculating about, off-label use of these medications, because you can't really have people going around using these medications that might actually increase resistance to those medications and lose that drug for people with HIV. Thankfully, though, this really didn't get picked up, and people understood that they shouldn't be jumping on changing everybody to Truvada. So what about people's risk? People who have HIV, do they have an increased risk compared to people without HIV? And some studies have gotten into this as they've gotten bigger and bigger studies. And I think that it's still, I'll preface this to say, it's really still being disentangled what HIV contributes in terms of a risk for severe disease. So in this large study in New York State that looked at 3,000 people living with HIV, what they found is that there was no difference in the diagnosis rates compared to people not living with HIV. So at least in New York, it looked like they were getting infected and diagnosed at about the same rate, but they did appear to be getting hospitalized more often. So that's shown over here with these increased rate ratios. And also were more likely to die from COVID-19 compared to kind of all comers of people not living with HIV. And then there was a very big study that came out of the UK where they have much better access to medical records, where they had they looked at 17 million different health records in the UK. And there they found that people with HIV had a higher risk of death than those without HIV, even when adjusting for a number of factors. So here's kind of an all-comers figure showing cumulative mortality among people who had HIV, which is shown in blue, and people without HIV in red, and showing this over kind of the first 6 months of the pandemic. And because they had all these records, they were able to control for a number of different variables. They looked at different comorbidities that are more common among people with HIV. They controlled for that. They controlled for what they called social deprivation, which is sort of a poverty index, and ethnicity and smoking. And the association was a little bit attenuated when controlling for that, but they still found that the risk was still high, just HIV. What they couldn't look at, because it wasn't available to them in the records, were more detailed information about the people's HIV itself. So were they on ART? Did they have good viral suppression? What was their T cell count? So it's unknown if this increased mortality was really driven by a subset of people with HIV that did not have good immunity, basically, who had some sort of immune defect still. And this is just to show that there's so many factors that are almost impossible to control when trying to disentangle this, HIV and risk of COVID. So this is the Kaiser Family Foundation. This is just sort of a snapshot to say that 3/4 of the top 20 counties by HIV prevalence, so Los Angeles, Cook County, Miami-Dade County, Kings County, Queens County in New York, this is where HIV prevalence is the highest. And this is also where COVID-19 was the highest, cases and deaths. So as an epidemiologist, that's called a secular trend, where you have all around you is more COVID. So therefore living there itself is going to give you more COVID. It's very hard to tease this out. So if you read in different places, you'll see HIV is listed as, yes, it's a risk factor. no, it's not established as a risk factor. But I do want to say, and to encourage to say, you know, the statistics are there, just all comers, very broad picture. You know, I do think you can consider HIV a risk factor for progression to severe disease. So how did people do in the last year who were living with HIV? I mean, we really don't have clinical outcomes to say how did they do, but there's some data that shows, you know, like everyone else, clinical care was really profoundly disrupted. So HIV testing and viral load monitoring declined during the first year. It's kind of picking back up now. Telemedicine, this was interesting to see how, you know, whether this is a pro or a con for people with HIV. These visits really did increase, but the total ambulatory visits decreased significantly. And in the first 6 months, one study showed that this decreased by up to 78%. And then looking at PrEP prescriptions, that's pre-exposure prophylaxis. That's a prescription for antiretroviral therapy that you can give to people who are at risk of acquiring HIV. That will significantly reduce their risk. These prescriptions decreased by 21%, and there was a 28% drop in new PrEP starts. Now, is that a bad thing, good thing? We have no idea. You know, a lot of people stayed home and were locked down. Probably were not like out and about on the town having a lot of sex, so maybe PrEP prescriptions were not a big deal. But these decreases were largest for younger people and those who had to pay with cash or patient assistance programs. So that's worrisome. That's a red flag that there were very vulnerable people who were at risk for HIV that weren't started on PrEP. So the long-term impact of that, I think, really is yet to be seen for this population. So this is a summary of the clinical features for people living with HIV. I think you can say, stepping back without overthinking it, HIV is a risk factor for progression to severe COVID-19. Now, there are many specific aspects of HIV that may drive that increased risk of diagnosis and progression. Could be the overlapping race and ethnicity of the population, where they live, the increased likelihood of their significant comorbidities, potentially their overall increased exposure to congregate settings. Probably what it's going to come down to in the end, apart from that, in terms of pathophysiology, is probably going to be the advanced stage of HIV disease and their low CD4 count. And we still are trying to understand immunocompromised people in general and how they do with COVID-19 and how they do also with vaccination. And you know, a T cell defect is not the same as a humoral cell or humoral immunodeficiency. So, you know, who knows for sure what aspect of this immunodeficiency in HIV is driving some of this progression. So I think that still remains to be seen. Clinically, you know, it's very similar to COVID, right? People with HIV are presenting with a similar spectrum of symptoms, but I would say just monitor them more closely than you might otherwise, especially in the outpatient setting where you might be inclined to say, okay, they're going to do fine, maybe keep a little closer follow-up. So what about treatment of COVID-19? Now, I'm not going to go over the treatment of COVID-19 because, first of all, you probably had 10 lectures on that already. So instead, what I want to do is just highlight some key points about people living with HIV and what might be important to know for that population. So most of your patients, even internal medicine, if you have a patient that you're following who happens to also have HIV, you know, you might get called because they tested positive as an outpatient. So what are you going to do in that scenario? This is a theme, but there are no difference in the treatment recommendations for people living with HIV compared to those without. So that's the first thing. So if you forget everything else, just always remember there's really no difference. Just go with what you know so far for COVID-19. And most patients in general, and this is true for HIV too, they, you know, more than 80% will do fine as an outpatient with just monitoring and really require no specific therapy. I do want to point out, however, that there are 2 monoclonal antibody therapies that have been proven in randomized controlled trials to reduce the rate of hospitalizations and death, particularly in those who are at risk for progression to severe disease. These are the Lilly combination and the Regeneron combination. You may know them as BAM, like bamlanivimab, casirivimab, these combinations. I personally feel like these monoclonals have been underappreciated. And the reason for that, of course, is that they are expensive and difficult to give. But scientifically, they're pretty interesting. And I do want to keep them in mind and remind people about how they can be used effectively. So these antibody therapies are authorized and now additionally recommended for patients newly diagnosed with COVID-19 and mild to moderate COVID-19 and high risk for progression to severe disease. This is why I keep kind of saying, like, I'd like you to think about HIV as one of these risk factors. Other outpatient therapies that are milling about, not so much in New England because we're kind of like a strict evidence-based community, but around the world, oh boy, are they all trying these other outpatient therapies, colchicine and ivermectin, fluvoxamine, and really none of those should be used outside of the context of a clinical trial. So the only thing you can use that's authorized and data-driven are monoclonals. So I want to show you a little data for Regeneron. We were involved in some of these studies at BIDMC. This is a study that looked at the treatment of newly diagnosed COVID-19 in individuals who were at risk for progressing to severe disease, but at the time of diagnosis weren't particularly sick at all. So this is about 1,400 people, and 730 or 750 of them got placebo and or Regeneron. So looking at the risk of COVID-19 related hospitalization or death for 1 month following diagnosis, about 3% of the placebo recipients progressed. So just like everyone else in the high risk, in the outpatient setting, most people do well. However, having said that, there was a 70% reduction in the number of individuals who did progress to severe COVID-19. With only 1% among the antibody group. And it also reduced the length and duration of time that people had symptoms. And then some other data also showed a reduction in the amount of virus in their nose. This was a reduction of about 4 days of symptoms. So who cares, 14 days, 10 days, what's the difference? Well, it's actually really important for household transmission. So if you're trying to also prevent COVID in the household, it's a good idea to try to reduce the duration of symptoms. Now, what if you get that call for your perfectly fine patient who has no symptoms, but just happened to test positive on some kind of screening test? So in this population of individuals, and these were people who were not particularly at risk for severe disease, 100 of them got placebo, 100 got Regeneron antibodies. And I shouldn't be saying Regeneron antibodies. I should be saying the generic long names, but it's too difficult. But this is interesting. So 100 people who had asymptomatic infection incidentally detected, 42% of them went on to develop symptoms. Most of these were mild, right? Like runny nose type of thing, but it's kind of interesting to see how many did progress. And for those who got the antibodies, 29% of them progressed to cold-like symptoms. So it's a reduction of 31%. But I think what's most significant here is, again, the reduction, 45% reduction in the total duration of symptoms that people had, which is very relevant for transmission. And also, 100%, so to speak, reduction in severe disease. So 6 people in the placebo group, 6%, went on to be hospitalized or go to the emergency room, and none of the antibody treated patients progressed. So I'm pointing this out just because, like I said, I don't feel like it gets enough attention. The randomized controlled data for these antibodies are really very good. What are the key points for treatment of hospitalized patients with HIV? The treatment recommendations are the same as for the general population. And as you guys all know very well, those key modalities are dexamethasone, remdesivir, plus or minus baricitinib, or tocilizumab is back on the scene. Remdesivir is an antiviral. It does not interact with antiretroviral medications. So antiretroviral therapy should be continued. And when I say here monitor for drug interactions, I'm really actually talking about like dexamethasone or tocilizumab, these other kind of medications. And there is just general principles. So if your patient is diabetic, think about the high dose steroids. There's really no evidence at all that any particular HIV antiviral has activity against SARS-CoV-2. You may recall in the beginning of this pandemic, people were kind of jazzed about lopinavir, ritonavir. It wasn't a crazy idea. It had been shown to have activity, clinical activity against SARS-CoV-1, the first SARS pandemic, or thank God not pandemic at the time, but first outbreak. And it was widely available and there was absolutely nothing else. So a lot of people did try lopinavir, ritonavir, but there was a very good randomized controlled trial that showed that it had no benefit and it fell off. There are the observational studies, which I mentioned already, that said that tenofovir might have some sort of benefit, but they were not well controlled. And so the Infectious Diseases Society of America does not recommend any change in antiretroviral treatment, out of consideration for COVID-19. So no change, trying to prevent it, no change trying to treat it, just keep it the same. So how about prevention of COVID-19? This is a theme here, but prevention recommendations are no different than the general population. Key modalities, monoclonal antibody therapy. So I'm not going to go through this for prevention as much as I want to, only because it's not authorized yet, but it has been submitted to the FDA for EUA, so you may see that. It has excellent randomized controlled data for post-exposure prophylaxis. So among household contacts of someone who was recently diagnosed is very good at preventing people from getting infected. But the mainstay of our prevention right now are our COVID-19 vaccines, and I am going to talk about them a little bit here because it's so relevant for all populations, but also people with HIV. But I'm only going to talk about the ones authorized in the US, where I'm just talking about domestic here. I mentioned here masking guidelines, very controversial, very dynamic, changing all the time. And I really think you should think about masking guidelines for your individual patient based on their immune status. So if they're quite immunocompromised, I would still wear a mask. I would still recommend wearing masks indoors. However, if they are vaccinated and not immunocompromised at all, have a fantastic CD4 count, I would just treat them as you would any other patient in terms of those guidelines. So you guys have heard about vaccines. Everybody hears about vaccines. Sometimes I think, my God, if I never hear the word vaccine again, I'll be happy. But I want to spend a few slides to just update everyone on sort of the state of knowledge about these vaccines as of today. So the Pfizer vaccine, BNT162b2, was shown to be 95% effective in preventing symptomatic COVID-19 in a large phase 3 trial. 9 of the 10 severe cases occurred only in the placebo group, and among adults over 65, efficacy was retained at 92%. What's new now is that we know that in the real world, this has been borne out. So for example, in Israel, the vaccine was shown to be 92% effective against all infections, including asymptomatic infections in Israel. And there is a lot of promising data about Pfizer protection against the new variants. I'm going to go into the variants like on a couple of slides in a little bit, because I do want to update everybody that there are new names for the variants. So the World Health Organization is very committed, and rightfully so, to preventing naming viruses after their point of origin. So either people or locations. It's very stigmatizing to do so, and it's also stupid because these variants are immediately global and have nothing to do with where they came from. But the numbers are driving everyone crazy. So now they've changed their names into something a little more simple. So I'm going to try to introduce those to you today. So Pfizer has been shown in a couple studies to be really good against some of these variants. So in the UK, it has 85% protection against the Alpha variant, 117. And in Qatar, which had been circulating this Beta variant, which is 351, which has shown in vitro to be quite evasive of immune responses, but actually was fine in reality. So this is, I think, very encouraging, and I'm going to say this as a theme because personally, I'm not as concerned about these variants, particularly protection against severe disease. So far, the vaccines are looking pretty good. So we all know the side effects. Most of us have been vaccinated with one of these mRNA vaccines, but local and systemic symptoms following vaccination are very common. There was originally concern about anaphylaxis, but it turned out that was pretty rare, so 5 events per million doses. Here is the Mona Lisa of scientific graphs, the Pfizer graph, showing the cumulative incidence in the placebo group of SARS-CoV-2 versus the vaccine group, and also showing that the dose, this response was seen after the first dose. Within about 2 weeks, protection starts to be observed. Now, Moderna, also mRNA, also like 94% effective in preventing symptomatic COVID. 30 of 30 severe cases occurred in the placebo group, and efficacy was maintained among the elderly. There's not as much data about Moderna. I think it's because it's kind of a US vaccine, honestly. Like Pfizer has been rolled out much more so around the world in Europe. So we don't have as much data, but what little data we have shows that in the real world, it still looks about 94% effective. And there's not a lot of data on the protection against variants, but there wouldn't be a reason to think it'd be much different than what we see with Pfizer. Local and systemic symptoms very common. Anaphylaxis very rare. In the studies, there were a couple cases of Bell's palsy, so the FDA was kind of looking out for that, but post-vaccine monitoring has not identified an increase in Bell's palsy. And here's the Moderna graph showing the beautiful separation in the curves of cumulative infections. So Ad26, CoV-2. So this is a vaccine that's very near and dear to my heart because I like to say we invented it at Beth Israel Deaconess Medical Center, and we also ran the first study of it. Having said that, I know its weaknesses, and I am going to talk about them. So reduced efficacy, and also I'm going to get into it in terms of the side effects. So overall, 66.9% overall efficacy was demonstrated globally against moderate to severe critical COVID-19. So a little bit of a different endpoint, not really measuring mild symptoms. In the US, that efficacy was 74%. In Brazil, where a variant was circulating, which doesn't have a name because it wasn't a variant of concern, 66%. And in South Africa, very importantly, there was 52% retained efficacy against the Beta variant, which is 351, and it's probably, to my eye, the most concerning of the variants. It was still 52% effective, even against moderate COVID-19. The advantage of J&J is it's a single dose series. So it may be particularly good for disproportionately affected groups, such as the homeless, rural residents, justice involved, meaning like incarcerated, disabled, homebound, no or limited access to healthcare. So this may be a niche for this vaccine. Local and systemic symptoms, very common post-vaccination, but the main side effects that has been observed is this thrombotic thrombocytosis syndrome. So in a couple of slides, I'm going to get into that in more detail. This is a figure showing J&J efficacy against severe and critical cases of COVID-19, which is excellent. So over 80% protection. And significantly in South Africa, retaining over 80% protection against one of probably the most concerning variant. So there were people with HIV that were included in these trials, but they weren't a lot. So there's about 1,400 people living with HIV in trials of the EUA vaccines in the US. But most of these were the J&J study because of their large South African component. Participants in these trials with HIV were not really immunocompromised. They were all, by definition, had to have a CD4 count over 200, and they had to have controlled virus. So we don't have any data really at all in advanced HIV disease with these vaccines. Having said that, there was no significant safety issues or unusual concerns or anything that popped up from these studies. The sample sizes, though, for these numbers are very small, so there's little that you can say about, whether the vaccine had different efficacy. I do want to show one piece of reassuring data on the AstraZeneca vaccine, which is not authorized in the US, but is authorized by the World Health Organization. And in this study out of South Africa, they showed that out of 104 people living with HIV who all received the AstraZeneca vaccine, there was no difference in the safety. So vaccine side effects were the same, and no difference in immune responses. So now these were all stable patients, right? Not immunocompromised significantly. But here, after the first boost, the antibody titers were the same. And after the first injection, the same. And after the boost, also the same. So that's very reassuring. Doesn't look like there's anything unique to HIV itself that limits the immune response. And similar findings were found in a study done in the United Kingdom. Now, let me get into thrombosis with thrombocytopenia syndrome for a moment. This is a unique clinical syndrome. It's characterized by thrombosis, low platelets, and a positive antiplatelet factor 4 antibody, anti-PF4. And as residents, a lot of you are residents, you know this syndrome very well because this is HIT. It's exactly the same syndrome as HIT, heparin-induced thrombocytopenia. And new cases of this syndrome were observed first following AstraZeneca in Europe and then following Janssen J&J. And it most commonly presents as cerebral venous sinus thrombosis, and these are the veins, excuse me, draining the brain, which was the most common place where these thrombotic clots occurred. Excuse me. As much as we fans of J&J wanted to believe that this wasn't associated with our vaccine and that it was something more general or no bigger than baseline, it's not true. It really is associated with J&J. So looking in a lot of depth at more than 135 million doses of Pfizer and 110 million of Moderna, there were no confirmed TTS cases reported to VAERS. VAERS is the CDC vaccine adverse event reporting system. However, there were 28 confirmed TTS cases out of almost 9 million doses of J&J that were reported. I want to present just some updated data about the TTS cases that were presented at the Advisory Committee on Immunization Practices meeting, which was in May 12th, which was a follow-up meeting to the initial one that had a lot of press. So in that updated series, there were 28 cases of TTS after the Janssen vaccine. Janssen, Johnson, it's the same thing. The median age was 40 years and the range was 18 to 59 years old. So you may recall in the press, it was like, this is all people under 50, older people don't have to worry. The range is actually a lot larger, so 18 to 59. This is a syndrome that occurs in the first few weeks after vaccination. So 9 days, typically with a range of 3 to 15 days. This is also interesting. So this is not a syndrome that is exclusively in women. So there were 28 cases, 22 of them in women and 6 of them in men, not counting one case that occurred in a clinical trial in a man. So this is not something that leaves men out completely. 19 of these cases presented with CVST, was not associated with being pregnant. It was not associated with prior infection, not associated with people taking estrogen or oral contraception. So that's the vaccine. Here are the rates of TTS after vaccination out of about 9 million. Just rare, it's somewhere between like 1 in a million to maybe 12 in a million among the highest number, which were in 30 to 39-year-olds. But the number of cases, when you start subdividing it like this, is really not that high. So I would just say in general, it's somewhere between like 2 and 10 events per million. How do you evaluate this syndrome? So patients should seek immediate care. If they have new petechiae or bruising, which indicates thrombocytopenia, if they have unabating severe headache or new focal neurologic symptoms or seizures, I mean, come on, we know that has to be evaluated, but that's CVST. And then other signs of clots, because a lot of these people, they did have CVST, but not always, and they often had, in addition, some other type of clot, and it can be arterial or venous. So some people had mesenteric ischemia as their presentation, or pulmonary emboli, so it can kind of be like all over the place. If you see a patient like this, they should be evaluated with a CBC to look at their platelets, a D-dimer to evaluate clots, and then HIT testing and imaging for the site of thrombosis. We're learning a little bit more about the best test for these anti-PF4 antibodies, so that evolves a little bit, but most hospitals have a test for that. And the diagnosis is suggested if it's occurred 4 to 20 days after vaccination, or if you have any of these findings. Most of the thrombocytopenia was pretty significant, less than 50. So, it has to be, it can't be like 149 that, I might squint at that. It's true thrombocytopenia. Management, treatment should be with, non-heparin, non-warfarin anticoagulant, treat it like HIT. Do not use heparin. And this is just a reminder, if you see a suspected vaccine side effect, it just has to be suspected. You really don't know. It's not up to you to figure out if it's related. It's just maybe related. Report it, because this is the only way we know about these side effects, is if people report them into the VAERS. So just go to the VAERS, Google VAERS, and it's quite easy to put stuff in. Okay, so what about the future of SARS-CoV-2 evolution? Most SARS-CoV-2 mutations are either detrimental or neutral. But a small number affect the infectivity, infectiousness of the virus, or disease severity, or the ability to evade host immunity. The first 11 months of the pandemic was evolutionarily quite stable, but since late 2020, different sets of mutations have arisen, and this is likely in response to increasing immunity in the human population, which puts immune pressure on the virus to mutate. And several variants of concern have emerged globally. This is a graphic from my favorite website, nextstrain.org, which looks at the proportion of different variants in North America over time. So this is starting at the beginning of the pandemic to now. So in the beginning, most of this purple is a B.1 strain, sort of like a very close relative to the Wuhan strain. And this was quite stable with some kind of random mutations that were pretty much neutral. And then you can see in the late fall, the dominance of this variant, now called the Alpha variant, which is the one that originally was noted in the UK. And I want to note here this sort of climbing hill of other variants that are coming up that are starting to compete with this Alpha variant. So we are keeping an eye out on this in the United States, because this is a more diverse group of viruses than we've seen. This is a snapshot of what's going on around the world. So North America, I showed you, is now mostly this Alpha variant. South America, though, you see a different pattern, a big uptick in what was called P1 variant, mostly heard about it in Brazil. This is now called the Gamma variant. And then in Africa, you saw a different picture, which was this big Beta variant, or 351. And then in Asia, what I want you to see is here, which is a big uphill of this orange, and this is India. And what's happening in India is what they've now called the Delta variant, which is 617.2. What I want you to see and notice here is that global variation occurs. Each region is having its own pandemic, and variants of concern are emerging simultaneously in different regions as the pandemic progresses. But they're also mixing. So here in the US, we now have the Gamma variant, Beta variant, Delta variant. They're all here in the US. So we're going to have to see, as we get into the fall, how these different variants compete with each other. So I stole something from the internet, but I hope I'm giving proper credit to Eric Topol, who's very active on Twitter. And he made a fantastic infographic a few days ago that I just have to show you, which shows the different variants of concern and their new names, and a little cheat sheet about their transmissibility, immune evasiveness, and what we know so far about vaccine effectiveness. So there's a couple of these variants that look like they're more transmittable. a couple, like I told you, this 351 that originated in South Africa that looks to evade immune responses. But importantly, all of the vaccine data we have so far shows effectiveness, particularly against severe disease with all of these variants of concern. So let me wrap up here, just a few minutes left to talk about some big picture observations about kind of crosstalk between these two pandemics. So what about the contribution of HIV research? I could probably have a whole hour lecture just talking about, all the work we did, have been doing with adenovirus 26 that helped pave the way for the J&J vaccine, monoclonal antibodies. I say we, of course, like this is all 30 years of HIV research. But for example, development of vaccine technology really came out of HIV research that was used for the COVID vaccines. Experience with monoclonal antibodies for infectious diseases, I mean, that goes back a long ways, but a lot of research has been going on in the HIV world on broadly neutralizing antibodies for HIV. Very importantly, we had an established infrastructure for massive phase 3 clinical trials in the US that were based on the HIV networks. So the AIDS Clinical Trials Group and the HIV Vaccine and Prevention Trial Networks. These are hundreds and hundreds of clinical trial sites led by academic investigators that was completely redeployed for COVID-19 vaccine research. And if that did not exist, then we would not have been able to do the phase 3 trials that we did do this last year. And why do we have that infrastructure? Because of a massive commitment by the NIH and NIAID and Tony Fauci over the last 2 decades, 3 decades to build that infrastructure for HIV research. We have an appreciation for the importance of genetic diversity of these viruses. I feel like it goes without saying that HIV doctors and researchers know more about genetic diversity than anyone else. And then politically, there's a real history of grassroots advocacy in HIV work, ACT UP and Treatment Action Group. And these same advocates are out there pushing for increased access to COVID-19 trials, treatments, and vaccines. This is just an example of HIV advocates leading the way for COVID-19 vaccine access and equity. You may have seen something on the news about the US agreeing to waive intellectual property protections for COVID-19 vaccines. I mean, that's huge. We don't know how that's going to play out, but the fact that they even put out a press release saying that the Biden administration supported waiving those IP protections is pretty amazing. And this was pushed forward by some very classic advocates. So Greg Gonzalez, who has been in the forefront of HIV advocacy for years, and Peter Staley. These are some sort of legends in HIV advocacy who are out there fighting the good fight for COVID-19 equity. And finally, just a hodgepodge of lessons from COVID-19 for the future. So I think it's shown an example of extraordinary speed in vaccine development. It's been 30 years we've been working on the HIV vaccine. The scientific hurdles are tremendous, but I still think we can learn some from the collaboration and cooperation and funding that helped get COVID-19 vaccines out there. We've learned again, as we have to learn every time all over again, the critical importance of diversity and equity in research. I think there's now a public appreciation of like what a mess it is when we don't do research in pregnant women or children or the immunocompromised population, because we're now trying to catch up and understand these vaccines in that population. We've learned that administering monoclonal antibodies at the community level is quite difficult. This is important to me because I spend a lot of time working on antibodies for HIV prevention, and so it's sobering to see how hard it is to deliver them. Telehealth may be good, it may be bad, right? We don't know. Probably has to do with picking the right patients, but it may provide some new options for some of our HIV patients that are hard to reach. It's really important to have a portfolio of different options that are appropriate for different populations. And obviously we need more investment in public health at home and abroad. So let me summarize with the take-home guidance from the Infectious Diseases Society on management of people living with HIV. So continue antiretroviral therapy in people at risk for COVID-19 and continue their ART if they're infected, and just don't change anything. do not adjust their ART regimens with the goal of preventing or mitigating COVID-19 infection because there's a lack of data to do so. Maintain a high awareness of COVID-19 infection and the complications that can occur in people living with HIV due to the possibility of more severe disease, especially in those who have other things that put them at high risk. And do not use HIV status in decision-making about potentially life-saving interventions or enrollment in clinical trials. Okay, thank you. So I'm going to stop sharing and take a look at the chat and see what kind of questions you guys have. And please also just jump in at any time as well. Looking at the questions, let's see. So the first question has to do with if there's any utility to assessing immune responses in patients who've been vaccinated and who may be immunocompromised or be post-transplant. So this is definitely the topic of the day. And what appears to be coming out of the literature is that if you can't make antibodies, then you can't make antibodies to the vaccine. That's being borne out, a couple papers in JAMA, some other papers as well. So if you're a transplant patient and you're on significant immunosuppression, particularly agents like MMF, then they're showing about 50% of people don't develop any immune response at all to vaccination. And then this is coming out as well for cancer patients, transplant, excuse me, individuals who have gotten biologics, particularly like rituximab. So what we don't know is what level of antibody is required for protection. That's called an immune correlate of protection, and that data is still coming, right? Like we should have, kind of annoyed, I kind of want to have it out already. I would think it would be out from the big vaccine trials, but it's not out. So if you sent an antibody test and you got some kind of number, like I don't know how you interpret that number, and I don't know what advice you give your patient based on that number, because we don't know what that number means. I do have to say that if I tested my patient for antibodies after vaccination and they had none, and it was completely undetectable, I would be very concerned that they basically are not vaccinated. They may have a T-cell immunity that may protect them a little bit, but I don't know how much. So I probably would say for those individuals to kind of follow the same recommendations of having not been vaccinated. And we don't know yet for T-cell defects if that has an impact on vaccine immunity. So CAR T-cell transplants or like even the low CD4 counts in people with HIV. Okay, so how do I reassure patients who are hesitant about J&J? So the risk is very low, as is mentioned here, 2 to 10 million. How does that compare to baseline? It's higher than baseline. CVST, so clots and stuff like general run-of-the-mill clots, it's not higher than that. Those are very common, especially in this population. But this syndrome of having a big brain clot, which can lead to death. I mean, 2 or 3 of these people died. That's associated with thrombocytopenia, where you can't treat with heparin. That is definitely much higher than baseline. But I think the 2 to 10 million, it's very hard to make a risk assessment with something like that. I do feel like, as much as it pains me, I would say that if a person has access to 2 shots of an mRNA vaccine and it's something you think you can get to your patient, that's probably what I would pick. But if they can't, or 1 shot is the difference between getting vaccinated at all, then I would just reassure people to look out for these symptoms for 3 weeks, and then after 3 weeks, they're golden. Okay, any other questions? Looks like it's 9 o'clock, so not sure if you guys need to wrap up. All right. Well, thank you so much, everyone, for having me today, and I hope you have a good day. Okay, take care.